Breathing. We do it all day, every day. You breathe in, you breathe out. Seems pretty straightforward, right? Almost. Perfect. But what if I told you that a huge chunk of every single breath you take is, well, wasted? Let's dive into this really fascinating and kind of inefficient world of what we call physiological dead space.
All right, so here's what we're going to cover. We'll look at what this wasted breath actually is, break it down into a few different types, see how we can measure it, and talk about when it might start to increase. And then we'll get into why this is a huge deal for anesthetists.
Okay, let's just jump right into the big idea here.
Yeah, you heard that right. Picture this. About a third of the air you just breathed in. It does absolutely nothing. It never gets involved in that crucial swap of oxygen and carbon dioxide. I love this analogy. It's like putting gas in your car, but a third of it just disappears before it even gets to the engine. And that's exactly what's happening inside our bodies, all the time.
So, this whole thing has a name, of course. It's called dead space. Now, the official definition is that it's the amount of air you breathe in that gets ventilated. It enters your airways, sure, but it never actually reaches lung tissue that's being perfused, which is just a fancy way of saying supplied with blood. And if there's no blood flow, there's no gas exchange. Simple as that. That breath is, for all intents and purposes, wasted.
Look, if you want the simplest way to remember this, here it is. Dead space is just the ventilated but unperfused part of the breath. The air gets to the right place, the lungs, but it's missing its partner in crime, the blood. Without the blood, nothing happens.
Okay, so this wasted breath, it's not all one thing. We actually need to break it down into a few different types to really get what's going on here.
First up, there's something called anatomical dead space. And you know what? This part is totally normal. Everybody has it. Just think of all the pipes the air has to travel through to get to your lungs, your nose, your throat, your trachea, or windpipe. The air that's just sitting in those pipes, well, that's anatomical dead space. It's just passing through. It never actually makes it to the little air sacs, the alveoli, where all the magic happens. And for an average adult, we're talking about 150 milliliters of air with every single breath.
Then we've got alveolar dead space, and this is different. This is air that actually makes it to the alveoli, to the final destination. But for whatever reason, those particular air sacs don't have any blood flowing past them. In a super healthy person, this number should be practically zero. But when things go wrong medically, this is where a ton of that inefficiency we're talking about comes from.
So you take those two things we just talked about, the normal, everyday anatomical dead space in the pipes, and you add the alveolar dead space, which is the problem child, so to speak, and together, that gives you the grand total, physiological dead space. That's the whole shebang, the entire amount of wasted air in every breath.
All right, so we get it. This wasted breath is a real thing, but how do you actually measure it? I mean, how do doctors put a number on how inefficient someone's breathing is?
Well, what clinicians look at is something called the dead space fraction. And for a healthy person, that number is usually somewhere between 0.2 and 0.35. So what does that mean in plain English? It means that 20 to 35% of every single breath you take is dead space. It's just built into the system. It's part of the design.
And this chart really drives the point home. Look at the healthy lung on the left. That bar is down around 0.35, right where we'd expect it. But then you look over at the inefficient lung, and whoa, that fraction can jump to 0.5 or even higher. That means half of every single breath is being wasted. Just think about that. Your body has to work twice as hard to get the same job done.
Now, the math behind this is called the Bohr equation. And don't worry, we're not going to get bogged down in formulas. The core idea is actually really clever and simple. Basically, doctors compare the amount of carbon dioxide in your blood with the average amount of CO2 you're breathing out. See, if you have a lot of dead space, you're breathing out a lot of fresh air that never got a chance to pick up any CO2. That fresh air dilutes the CO2 coming from the working parts of your lungs. So the bottom line is, the bigger the gap between the CO2 in your blood and the CO2 you exhale, the more dead space you have.
So what would cause that dead space to grow? We're talking specifically about that problematic alveolar kind. What makes it shoot up so dramatically? Let's get into the causes and what happens next.
Okay, this is where you really see how breathing and circulation are tied together. A perfect example is a pulmonary embolism. That's a blood clot in the lung. It literally just blocks the blood flow to a part of the lung. So the air can get in, no problem, but the blood can't get there to meet it. It's the same idea with really low blood pressure or low cardiac output. The heart just isn't strong enough to pump blood to all the nooks and crannies of the lungs. It's a perfect illustration of how dead space signals a breakdown in that partnership between your heart and your lungs.
This table is a great summary of what can affect dead space. You can see a clear pattern, right? Anything that messes with blood flow, like low cardiac output or a PE, is going to increase dead space. But check out the equipment side of things too. A simple face mask or extra tubing adds what we call apparatus dead space. But what's really interesting is that a breathing tube, an ETT, actually decreases dead space. Why? Because it completely bypasses all those upper airways, that anatomical dead space we mentioned at the start.
And all of this brings us to the really critical question. Why do anesthetists care so much about this stuff? Why is it such a big deal in the operating room?
All right, here is the absolute key takeaway. The second a patient goes under general anesthesia, their physiological dead space goes up. Full stop. The combination of the drugs, the relaxed muscles, being on a ventilator, it all conspires to make breathing way less efficient than it is when you're just walking around awake.
Now, before we wrap up, it is super important to know the difference between dead space and its opposite, which is something called a shunt. Dead space, like we've been saying, is ventilation without perfusion. It wastes your ventilation, your breath, and that causes CO2 to build up. A shunt is the total opposite. It's perfusion without ventilation. It wastes your blood flow, and that leads to low oxygen. They're both bad news for sure, but they are fundamentally different problems.
So for an anesthesiast, managing dead space is this constant, delicate balancing act. They're using monitors, like a capnograph, to keep a close eye on it. They have to tweak the ventilator settings, maybe giving bigger breaths to make up for that wasted portion. And this is especially critical when they're working with kids, because their breaths are so small to begin with. Any little bit of extra dead space from the equipment can have a massive impact.
So, we started with something as simple as taking a breath, and now we've seen this incredibly complex dance happening between our lungs and our heart. The next time you take a nice deep breath, maybe you'll appreciate it just a little bit more. Knowing all about the breath you waste, what does that make you think about all the hidden, kinda inefficient, but absolutely incredible work your body is doing every single second just to keep you going?